Dr. Muhammad Sami Saeed. I will present today a lecture on a colorectal cancer. Lecture topics will be on definition of the tumor, etiology and pathogenesis of the tumor, pathological feature, gross and microscopic, clinical presentation and clinical symptoms of the tumor, and lastly the staging of the colorectal tumor. Definition of colorectal cancer. Colorectal cancer, it is a term used for an abnormal and uncontrolled new growth of cells that start in the colon or rectum. These cancers can also called separately as colonic cancer or rectal cancer, depending on the site of the origin of the tumor. Anatomically, colon consisting of four parts: the ascending colon, starting from the cecum and ending into the transverse colon, which cross the abdomen from the right to the left side, connecting to the descending colon. Descending colon goes downward to the sigmoid, and the sigmoid end into the last part of the digestive system, which is the rectum. Epidemiology of colorectal cancer. Colorectal cancer, it is a worldwide distributed tumor. Highest incidence rate present in United States, Canada, Australia, New Zealand, Denmark, and other developed countries. Excluding skin cancer, the colorectal cancer is the third most common cancer diagnosed in both men and women in the United States. Furthermore, the American Cancer Society estimated the number of colorectal cancer cases in the United States for 2015 to be as about 93,000 of new cases of colon cancer and about 40,000 new cases of rectal cancer. Also, colorectal cancer is the third most common cancer-related death, and it is expected to cause about 50,000 deaths by the 2015 in the United States. The peak incidence of this cancer is between 50 and 70 years of age, but less than 20% of cases can be seen in age less than 50 years, and male affected more than female. What are the etiology and pathogenesis of this tumor? The exact cause of colorectal cancer is still unknown, but there are many well-known risk factors for colorectal cancer. These include first, lifestyle factors, which includes diet, high red meat, protein, fat, and carbohydrates, all in increasing risk of cancer. Second, obesity. Third, low physical activity. Fourth, long-term smoking. And five, heavy alcoholic consumptions. All these will cause an increasing risk of cancer. The other risk factors including personal history of adenomatous polyps, whether it is tubular, tubulovillous, or villous adenomatous polyps, will increasing risk of cancer. Also, previous history of colonic cancer will increasing risk of cancer in the colon, even if it had been previously excised or completely treated. Third, personal history of inflammatory bowel disease, including ulcerative colitis and Crohn's disease, will increase risk of cancer. And fourth, family history of adenomatous polyps of colorectal cancer, will increasing the risk of colorectal cancer. 3. Inherited syndromes. about 5 to 10% of colonic cancer have an inherited gene abnormality, and these gene abnormality will resulting into developing of familial cancer syndromes, most important of which are familial adenomatous polyposis, which caused by mutation in APC gene, familial non-polyposis colonic cancer, which is also called Lange syndrome, Turcot syndrome, which is associated with an increasing risk of adenomatous polyps and colorectal cancers, and lastly, Buerger syndrome. Fourth, racial and ethnic background. It had been seen that African Americans have the highest colorectal cancers. Jews of Eastern European descent, Ashkenazi Jews have one of the highest colorectal cancer risk of any ethnic group in the world. What is the pathogenesis beyond this colorectal cancer? The combination of genetic or molecular events that resulting into a colorectal cancer, it is heterogeneous, including both genetic and epigenetic alteration. However, there are two important pathways for colorectal cancer. The first, called APC pathway, or adenoma carcinoma sequence pathway, and the second is the DNA mismatching repairing gene pathway, or microstillate pathway, instability pathway. The first is the classical adenoma carcinoma sequences, which is called APC beta-catenin pathway. It responsible for 80% of sporadic colonic cancer. This starts by loss of both copies of APC gene, whether germline or somatic loss of these genes, resulting in formation of adenoma. Then further genetic alteration will occur, including proto-oncogene like KRAS antigen, which will cause abnormal dysplastic cells in these adenomas. And with the progression of the tumor, additional chromosomal abnormality will occur, including tumor suppressor genes and other proto-oncogenes, ending into formation of an invasive cancer. The second pathway, what is called DNA mismatching repairing gene repairing deficiency, or microstillate instability pathway. This pathway starts with the loss of the DNA repairing genes, which are responsible for DNA repair. Loss of these DNA repairing genes will resulting into a microstillate instability, and this will result into stimulation and activation of other proto-oncogenes and other genes, and suppression of other pro-apoptotic genes, which ends into a formation of a mass, and this mass will grow and de-differentiated into a cancer mass. Now, pathology of the colorectal cancer. Several types of cancer can be occurs in these sites, colon and rectum. However, the most important type and most common type of colorectal cancer is the adenocarcinoma, which represent more than 95% of colorectal cancer of epithelial origin. Second, carcinoid tumor. This tumor starting from specialized hormone producing cell within the colon, within the intestine. Third, gastrointestinal stromal tumor, which is a tumor starting from specialized cells in the wall of the intestine called interstitial cells of Cajal. Fourth, lymphoma, which is starting or originating from lymphoid tissue in the colonic wall. And lastly, sarcoma, which originating from the connective tissue component of the intestinal wall. Grossly, all colorectal cancers starting as in situ tumor, then it will grow into a large mass. This mass usually in the right colon or proximal colon, seen as a polypoidal fungating or exophytic mass originating from one side of the wall of the colon. While those in the descending colon, the mass usually annular or encircling the wall of the intestine, causing narrowing and obstruction of the lumen, and it could be also depressed or ulcerated lesion, as seen in these pictures. This is an annular tumor narrowed and obstructing the lumen of the intestine, and this is an ulcerated lesion, ulcerated tumors seen in the descending colon. The majority of colorectal cancers are of adenocarcinoma. Adenocarcinoma are gland-forming tumor of variable size and variable configuration, lined by malignant cells and invading the layers of the intestine. Majority are well to moderately differentiated tumor with mucin production. However, it could be poorly differentiated and even could be in sometimes anaplastic tumors. Tumor cells will invade the submucosa, muscular layers, and extend through the whole wall of the intestine to the pericolic fat, permeating the perineural spaces and invading veins and lymphatics. Other tumor may having a lot of or abundant mucin component, and this will fill and accumulated within the intestinal wall, and this type of a tumor is called mucinous adenocarcinoma. Other types may accumulate mucin within the cytoplasm of the cells, resulting in the formation of a signet ring configuration, signet ring formation, and these tumors called signet ring cell carcinomas. Clinical features. Early colorectal cancer often has no symptoms, but as the tumor grows gradually, it will cause a mass and resulting into a bleeding, intestinal bleeding, and or intestinal obstruction. The right-sided colonic tumors usually produce infatigability, weakness, anemia of iron deficiency types, and weight loss, while those of the left side of the colon usually causing occult bleeding, causing cramping abdominal pain, lower abdominal pain, causing altered in the stool, and may causing intestinal obstruction. How we can detect and diagnose colorectal cancer? Simply by PR examination, rectal examination. Also, fecal testing for a blood, occult blood, barium study, colonoscopy, and sigmoidoscopy. Confirmatory biopsy may be needed also, ultrasonography, MRI, CT scan, CAT scan may be also needed. Furthermore, serum marker detections and estimation, including carcinoembryonic antigen and CA19-9. And lastly, we can do an advanced technique including detection of APC gene in the epithelial cells isolated from the stool, or from the epithelial cells isolated from the stool. Lastly, staging of the tumor. What we mean by stage? Stage is the degree of extent of the tumor in the body. What is the importance of the staging system? Staging system is essential for determining the choices of a treatment and to assessing the prognosis or the outcome of the disease. More than one system for colorectal cancer used for staging system. These including TNM staging system and Duke system. But the most important of which, of course, the Duke systems and TNM staging system. The two most important prognostic factors for colorectal cancer are the depth of invasion of the tumor within the wall of the colon and the absence or presence of lymph node metastasis. The TNM staging system, or also called American Joint Committee classification. This including T, which describe for how far the main tumor or primary tumor has grown into the wall of the intestine and whether it extending beyond the intestinal wall into the adjacent organ. N describe the status of regional lymph node, whether it is involved by the tumor or not. The M describe the distal metastasis or separate of the tumor away from the primary site. And colorectal cancer can spread in any organ to any organ, but the most common organs are the lung and the liver. As we see in this picture, these are the layer of the normal intestinal wall: mucosa, submucosa, muscularis propria, and the pericholic fat. As we see in these pictures, these are the stages of developing of the tumor within the wall of the colon. It will start as carcinoma in situ, then involving the mucosa, TA, extending into the submucosa, T1, invading the muscularis propria, T2, penetrating the muscularis propria into the pericholic fat, T3, and penetrating the whole wall of the intestinal wall and extending to the adjacent organs. This is T4. Duke system. Duke's classification divided into Dukes A, tumor limited to the wall of the bowel, lymph node usually negative, and this is carry 80% 5-year survival rate. Duke B, tumor spread beyond muscularis propria but lymph node negative, and this is carry a 60% 5-year survival rate. Duke C divided into C1 and C2. C1 is for a lymph node involvement, but the highest lymph node is still spared, still not involved by the tumor, and this is carry a 30% 5-year survival rate. C2, the lymph node, the regional lymph node, and the highest lymph node involved by the tumor. And Duke D is for the distal metastasis, which carry less than 5% 5-year survival rate. In conclusion, colorectal cancer is a common worldwide distributed tumor. Risk factor with genetic and epigenetic alteration leading to colorectal cancer. Adenocarcinomas representing the predominant types of colorectal cancer. Intestinal bleeding, anemia, and intestinal obstruction are the common presenting symptoms and signs of colorectal cancer. Staging is essential for determining the choices of the treatment and to assess the prognosis of the disease. Any question? And thank you.